So, 2019, folks, 2019. Probably the only way we'll get what we have to get done is to have a state of emergency. And if no one else will declare it, then let us declare it a state of emergency for the elimination of health disparities. So I want to just again thank the last panel, and especially to thank the Wilders for sharing their personal experiences with us. It's been very inspiring. Our next panel is going to discuss how the Affordable Care Act is being implemented in the offshore areas of the United States, otherwise known as the territories. The territories are, of course, the U.S. Virgin Islands, Puerto Rico, Guam, American Samoa, and the Commonwealth of the Northern Marianas. With me today to discuss this, the forgotten Americans, are Matt Herman, who is the legislative director for the office of Congresswoman Madeleine Bordallo of Guam, John Lawfer, the legislative director of Congressman and resident commissioner Pedro R. Pierluisi of Puerto Rico, and one of my own senators who chairs the Health Committee of the 30th Legislature of the Virgin Islands, Senator Clarence Payne. Could you put my slides up? Just to set the stage for this conversation, this slide presentation was prepared for a presentation I did at home. But just to give you a little background on the Affordable Care Act and the territories, and I'm going to skip over some slides, but you can see that in the House version of the Affordable Care Act, there was quite a bit of funding there for Medicaid for the U.S. territories, but the Senate only wanted to give us a 30% increase over what we had, and the White House 35%, which really was inconsequential in terms of the need. The territories' Medicaid is capped, and so while we wanted to get state-like treatment for Medicaid, the House did provide us with significant funding, but as you see, we had a challenge with the Senate and the White House. The Medicaid match provisions, the House provided us with approximately 75-25 match, but the Senate only wanted to change it from 50 to 55. We were at a 50-50 match in statute, could not be changed. The exchanges, the House passed version had $4 billion to be shared among the territories. We started out when we left there with territories not being eligible for exchanges at all. For consumer protections, again, the House made us eligible for the consumer protections. We had a fight with the White House and the Senate after that. So the changes in funding levels from the House bill to the final, as you can see, the match changed. The exchange funding went from $4 billion to $1 billion, and that's after all of us, the delegates, our staff, and the caucuses to which we belong, the African American, Hispanic, and Asian caucus, fought for this. We were able to get from 75-25, we were able to get from 50-50 to 55-45. We were able to recoup $1 billion for the exchange only, and Medicaid, we were able to get up to $6.3 billion in the final bill. So let me just go on to, so the federal allocation to operate exchanges, we were given the opportunity to, if we did not set up an exchange, to put it into Medicaid. That's why that supplement Medicaid is there. But this is essentially what the territories got to set up an exchange. Now, the provisions of the Affordable Care Act that were available to the territories were many, but these two programs were never available to us, even though we fought for them. We could never get into that pre-existing condition insurance program or the early retirees insurance program. but just as an example, we did have improved quality of care. We, in the first year, over 1.6 million was rebated from plans that did not meet the 80% being spent on healthcare services. We got a $1 million grant to determine whether we could set up an exchange, home visiting program funding. Our health centers together got 1.6 million. And this is pretty much reflective of what the other territories got. And of course, we were able, our insured, both Medicare and private, were able to have preventive services without a copay. And the donut hole began to be closed for all of us, and the rebates were available. So that's just how things, I'm not going to go through the rest of the slides, but that's just how things went for the territories. So I'm going to turn now to our panelists to have them begin to answer a couple of questions. I know when I go home, and as late as last week, the question was posed, why are we not in the Affordable Care Act? Why are we not in the Affordable Care Act? So I wanted to go, and I wanted to ask each of you to tell us a little about what your individual districts are experiencing and what you're hearing from your constituents. Do you want to begin, Senator Payne?
Sure. From right here?
Yep.
Good morning. That's how we do correspond and dialogue from the Virgin Islands. So I'm saying good morning. Panelists, good morning to all. I want to first commend the delegate for once again being a visionary in the healthcare, health industry, and the need for these types of discussions in a formal way. And I want to thank her publicly for putting it together. Let's give her a round of applause for doing this, please.
That applause includes Dr. Britt Weinstock.
Yes, whoever else is part of the team, kudos to you too. The Virgin Islands, like the territories, are in a very peculiar predicament. I firmly believe that the delegate did everything she could for the years, from the time our amazing president got elected up until now, to get us full parity into the Obamacare affordable plan. And our territory, in particular the Virgin Islands, we have a very, very high uninsured population. According to the latest numbers, we might be facing like 40% of the population who doesn't have health insurance. Recently, we began to have a lot of public discussion about why it is so important for us to have health care in the Virgin Islands. And come to find out, we might not even have providers in the Virgin Islands to provide for individuals, to provide for small businesses, to provide for those who have pre-existing conditions.
You're talking about insurance providers?
Insurance providers itself. Our granddaddy provider, Cigna, recently dropped all companies with 50 or less employees. The Bar Association, they subcontracted out their pharmaceutical billing component, and the issues continue to be compounded. And I know for a fact that the Affordable Health Care Act was supposed to cover all Americans. But like the heading of today's discussion, the forgotten Americans. You know, every entitlement that has ever passed since we became a part of the U.S. through the Territorial and Organic Act or whatever, we have to continuously remind Congress, the Senate, and the presidents, what about us? Every single one. We have to go back to remind them time and time again that we are supposed to be a part of this greater body of democracy. So we have some challenges facing health insurance and health care in the Virgin Islands. As a result of not having health care, many people without insurance go to the hospital which is causing our hospitals to have uncompensated care to the tune of about 25 to 30% of their budget. So you know what that is doing to the general fund, to the hospital fund. It has a spiraling effect. So I'm looking forward to the discussion, and I don't want to take up too much more time, but we do have some challenges. I do want to say that the components of having us keep our children to 26, commendable. I understand that has really caused a boon for a lot of medical practitioners, because those are the years that most people have babies and, stuff like that. So we do anticipate the doctors in the Virgin Islands speak very highly about some components of it, but it's time for parity and it's time for justice.
Right.
Thank you.
And our hospitals, by the way, are not eligible for disproportionate share payments, which keep most hospitals afloat.
Wow.
John Laffer?
Sure. I'm John Laffer. I am the legislative director with Congressman Pierluisi from Puerto Rico. Just to go back and set a little context here, there's 3.6 million U.S. citizens in Puerto Rico. It's probably another million U.S. citizens, or 750,000 in the other territories. As U.S. citizens, if they're not happy with the quality of care they're receiving in the territory, all they have to do is hop on a plane, they get a one-way ticket to Orlando or New York, and then they get treated like any other U.S. citizen in the state. So there's an escape clause if you don't provide sufficiently good quality of care in the territories, and that's what's happening. Puerto Rico is losing about 1,000 people a week to the states. They're going everywhere, not just to historical places like New York. They're going to Florida, Ohio, California, everywhere. And a main reason this was happening is prior to the enactment of the Affordable Care Act is that the territories were treated in an extremely unfair fashion under federal health programs. The main federal health programs obviously are Medicaid and Medicare. Medicaid is a shared federal-state program. In the states, if your income fell below a certain level, you automatically qualified for Medicaid, and as long as the state could meet its match, the federal government would chip in its amount. In a state like Mississippi, Mississippi would pay 30%, the federal government would pay 70%. That wasn't the way it was in the territories. The annual amount of funding that the federal government provided to the territories was capped, so that there was an annual cap. In Puerto Rico, the cap was about $300 million. Compare that to Mississippi. Puerto Rico's twice as poor as Mississippi, has about twice as many people. Mississippi was getting $3.5 billion a year from the federal government, while Puerto Rico was getting $300 million. You can imagine the effect that has on the quality of care. The Congresswoman's question was, do people in Puerto Rico or in your territory think that the Affordable Care Act applies? And the answer is that there's a lot of confusion. When people think about the Affordable Care Act in the states, they tend to think about the exchange, the federal tax credits to go purchase insurance on the exchange. Some think about expanded Medicaid. Other folks, particularly those who are critical of it, think about the mandates for individuals and companies to have to purchase or provide insurance to their employees. None of the main aspects of the ACA apply in the territories. There's no individual mandate to purchase insurance. Companies do not have to provide insurance to their employees. And in fact, the exchange doesn't apply. Even though we were technically made eligible, there wasn't sufficient funding given for us to apply it. So all the territories took the option of taking their exchange money and applying it to their Medicaid programs. So we are the only jurisdictions in the country where the exchanges don't apply. That said, a Puerto Rican can get on a plane tomorrow and move to Orlando, and as soon as they take up residence in Orlando, they qualify for the exchange if they meet the income requirements. So while we did very well on the Medicaid piece of tripling the funding we got, because we don't have the mandates or the eligibility for the exchange, when you ask a typical person in Puerto Rico about the ACA, the typical person on the street won't really understand how the bill is helping them or whether even if it applies in Puerto Rico.
Guam?
First, thank the Congresswoman, the CBC, and Brit as well for this chance to talk about it. We don't often get a chance to talk about how the territories are treated under the Affordable Care Act. And I think one of the messages that you're getting right off the bat here is that each of the territories, quite frankly, has some very unique challenges with how we're implementing the Affordable Care Act. From the Guam perspective, I'd have to sort of agree here with what John said. I think there's a lot of confusion out in Guam and, quite frankly, the CNMI about how does the Affordable Care Act apply, but more importantly, how does this impact my day-to-day life? We've heard from some of our, we hear on almost a daily basis from our insurers who are having some real challenges in trying to implement the Affordable Care Act, both because of challenges with the local government, but also the sort of hodgepodge way in which the bill or the legislation applies to the territories. And so we have been working very closely with them to try to address their concerns and their challenges. Unfortunately, it's been on a kind of issue-by-issue basis and not in a comprehensive fashion. But from a constituency, we really didn't have this dialogue about the Affordable Care Act until the last election when some folks tried to make an issue of it, not just on a national level, but specifically there in Guam. And we, I think, did something very similar to what the Congresswoman began this session with, which was explaining to people, here's what we had in the House bill, which we can control. Here's what the Senate bill and the White House proposals had. And this is why we ended up with the bill that we ended up. I think when we explained it to people, because we had already been talking to them about other issues that were challenging, particularly in the Senate, they kind of came to understand why the bill was the way it was. So we kind of moved beyond that discussion more to the point of how do we make this better for the territories. What our insurers constantly come to us with is, well, can you repeal it, or can you get rid of it, or can you do this in legislation? And we've constantly made the point, and I think you're all well aware of this, which is it's a political hot-button issue. And so while we may pass bill after bill that deals with it in the House, there's not any real effort to address some of the problems that we have with the Affordable Care Act, whether it's with the territories or whether it's nationwide. And so what we've done is we've worked with HHS and CMS to try on, again, unfortunately on an issue-by-issue basis, to address the concerns of the insurers. And moreover, we've thrown a challenge back to our own local government, which is, you know, we did get this additional pot of the $1 billion that then got divvied up among the smaller territories. How would you try to figure out how to use that money? And since we've decided not to set up an exchange, how do you still implement the broad tenets of the ACA, use some of that Medicaid money, and there's section 1115 of the ACA that allows for pilot programs and demonstration programs. And what we have found is HHS and CMS have been extremely flexible and want to work with us to address these challenges. So we've thrown that back to the local government and said, here's some things to think about, and here's how you might want to go about it, and to the extent that we can, facilitate that dialogue. The one other thing that I would mention, and that is unique to Guam, the CNMI, and Hawaii, although we won't deal with Hawaii right now, is something called compact migrants. The United States has compacts with the freely associated states, Palau, Federated States of Micronesia, and the Republic of the Marshall Islands, where we basically provide defense for these island nations, which are independent and sovereign, for defense access. But what the people who live in the freely associated states can do is travel freely to the United States. And because the economic situation in those islands is so depressed, they often leave and don't return to where they came from, which was the intent that they'd go to Guam or Hawaii, train up, come back and build their economies, but we don't see that happening. So they become a charge to our local government in trying to provide that health care. And while we do have a very significant influx of Medicaid dollars, the FMAP is a challenge in terms of spending that money. But yet again, in working with CMS, there are other things that, quite frankly, Guam, at least, was not taking advantage of that could provide some specific amount of care to compact migrants, because they right now are not eligible for Medicaid. That's the easy fix, but again, legislatively, there's not much going on. So locally, that is a very specific and unique challenge that Guam and the CNMI as well have to deal with regards to implementation of ACA.
Wow. Okay, now, we showed, and I think, John, you mentioned that we got a significant increase in Medicaid. We also got the ability to set our own poverty levels. Has that been able to, how have any one of our districts been able to increase coverage utilizing the additional Medicaid dollars and the ability to set our own poverty level? The poverty level that we use is the standard U.S. poverty level. It's not Hawaii and Alaska, their income eligibility is significantly higher. I know in the Virgin Islands, our cost of living is significantly higher even than Alaska and Hawaii, yet we're at the 11,000 eligibility level. So now we have the ability to set our own poverty level, and we have some more funding. Not all that we asked for, not all we would have gotten in the House, not all we need. How has that impacted, how has that been able to increase the number of insured in the territories?
Well, I know for the Virgin Islands, it's still woefully low. A few years ago, and I'm not talking about 3 or 4 years ago, our Medicaid cap was $5,000 a year. And it was set in 1976.
That's the income at which an individual would have been eligible.
Eligible for Medicaid. Recently, within a year or so, it's raised to $6,500, which is still a struggle. But I read today, I believe somewhere, where we are now eligible for additional dollars coming to the territory to expand and increase the cap. Once again, you know, facing those challenges and then expecting a free society to be responsible for its citizens with those stipulations in place, you know, is kind of a paradox. Because as a offshore territory, we want to believe and we want to feel that we are a part of the greater good and the greater democracy. But when you begin to analyze on the surface, you don't even have to dig deep, just on the surface, some of the disparities, some of the challenges, some of the laws, some of the actual implementation of various acts is very frustrating. It's very frustrating, and we have a struggle ahead of us. You know, many people believe that having a discussion about the original intent of the Affordable Health Care Act might be surfacing again. Because many states, many territories, it's still not addressing the primary issue of the average person in America.
In Puerto Rico, so just to explain what we've done with the additional money we received under the ACA, as Congresswoman Christensen mentioned, we got a lump sum of $6.3 billion for all the territories to share for its Medicaid program. Puerto Rico got about 89% of that, of $5.4 billion. Then separately, there was $1 billion that was theoretically available for the territories to operate in exchange. All the territories decided to use that money for Medicaid as well. Puerto Rico got $925 million of that $1 billion. So the total of $5.4 billion plus $925 million, we're talking about $6.3 billion additional dollars for the territory to use for its Medicaid program. That's a lot of money. And that is available starting in the fourth quarter of 2011 through 2019. What Puerto Rico has done is we've taken our Medicaid program, which used to cover about 1 million or so people, and we also had a state-run health program that was covered entirely with Puerto Rico dollars. We've taken a lot of folks, specifically single folks, folks without kids, who were on the state plan and migrated them over to the federal state Medicaid program. And now with that, with our FMAP of 55%, for those folks, Puerto Rico will pay 45 cents on the dollar and the federal government will pay 55 cents on the dollar. We've been able to migrate about 370,000 people. It's not clear if we've been able to cut meaningfully the number of uninsured people on the island. Ironically enough, Puerto Rico is a very low level of uninsured folks, about 7% of the island's population, which is certainly much lower than it sounds like the VI. We have a lot of underinsured people, but we don't have a lot of uninsured people, about 280,000 folks all told. It's not clear whether with this additional Medicaid money, we've been able to take folks who previously had no insurance and bring them onto the Medicaid rolls. Really what we've done is migrate folks who are getting state-only coverage and brought them to the federal state plan. I don't think, Congresswoman, that we've made any changes based on the federal poverty line. I think our Medicaid program covers folks up to about 80% of the federal poverty line. States now are at 100%, they can even go up to 138%, I think, or 133 under the ACA. We're still stuck, given our capped funding, at covering up to about 80%. So you have a lot of poor folks who, in Puerto Rico, who don't qualify for Medicaid, where if they moved to the States and took up residence there, they would qualify for Medicaid in the States.
Out in Guam, one of the challenges we've had, and we sort of began to address it in the Affordable Care Act, is actually getting very good data, medical data on who's covered, who's underinsured, et cetera, et cetera. I think, notionally speaking, much like Puerto Rico, there was pretty good overall coverage, but I would say most were probably underinsured, which is why a lot of the plans are non-compliant or will be non-compliant soon. You know, what you have in Guam is we do have a local program called the Medically Indigenous Program, MIP, and a lot of folks were covered under that local program. Again, we have noticed a migration of them off MIP to the Medicaid, some sort of Medicaid program, Medicaid funding, and that freed up that local money to, again, try to address some of the challenges we have with compact migrants. So unfortunately, I couldn't say that we've seen a great number of additional people insured. That level of fidelity doesn't exist right now, or where people aren't sharing it with us. But you know, I think that there are some cases that we've heard of where people have written to us where their kids were covered because of the age 26 provision, where they otherwise wouldn't have been covered, whether they're here in the States or elsewhere. So we do have some success stories there. I think, again, you know, the local government, the challenge in Guam, and I think it's the same in CNMI, is we have a local government that has really been challenged to understand how to implement ACA. And while I think there is guidance out there, something's been lost in translation. And so we're trying to, I think, re-engage to try to find ways to address some of these specific concerns that they have so we can cover more people and really get at the heart and the core of what ACA is, which is making sure everyone has coverage. One of the things we do here, again, another challenge to our local government has been, yes, the individual mandate does not apply to Guam, but that should not stop our local government from implementing their own individual mandate, which is something they can do. And again, it doesn't necessarily cost them money if they work with HHS to take that additional money, the about $24 million that we have, that they could essentially use as sort of a high-risk pool.
Well, I'd like to ask both John Laffer and Senator Payne about that individual mandate. Is that something that's being discussed in Puerto Rico or the Virgin Islands? And do you see that as something that we could be feasible for us?
It'll be challenging in the Virgin Islands because we don't have the pool of insurers in the territory. And I think that with that in mind, it limits the competition, which I think is very crucial. Let me give you an example. If you worked for the government of the Virgin Islands and you had the government insurance, which is through Cigna, your out-of-pocket premium is $468 a month for the family. This is regardless of your income. So if you make $20,000 a year and you want to insure your family, that's about 26% of your income goes towards health insurance. If you're the governor and you make $150,000 a year, your health insurance is $5,600 a year. We have some. I think that is hitting home for some of you now. You're a school teacher, and your income is $32,000, and you want to insure your family. It's $5,600 out of pocket a year. We have some challenges.
The short answer is in Puerto Rico, no. There's no discussion of instituting an individual mandate at the local level, and the reason is simple, is that on the federal level, the reason that a mandate had some level of political support is that it came with federal subsidies for lower income folks. You can't tell somebody who's earning 125% of the federal poverty line that they have to purchase insurance unless you're going to give them some assistance when it comes to their premiums and deductibles and other health care related costs. So if Puerto Rico, and just to step back, because I'm not sure we clearly explained the problem in the territories is that the insurers are required to abide by most of the consumer protection. So you have to provide access to preventative care. You can't impose annual or lifetime limits. Plans that were providing coverage to dependents have to provide it up to age 26. All those protections. You can't deny coverage based on pre-existing conditions or take somebody's coverage away if they get sick. All those great sounding things apply to insurers in the territories, but we don't have the other part, which is the mandate, which creates an adverse selection issue. The reason insurance companies in the states were willing to swallow the consumer protections is that they knew that younger, healthier folks would sign up because they have to, or else they face a penalty. So in Puerto Rico and the other territories, you have these insurers that are required to provide these protections, which is theoretically a good thing, but people aren't required to sign up. And people who are poor, if they do sign up, don't get federal assistance. So the only way this works, I think the ACA is a lesson that you can't do a hodgepodge or a patchwork of provisions. You either have to make it apply or not make it apply. And the problem in the territories is they made some things apply and not other things, and it's created somewhat of a mess. Still a much better mess than we had before the ACA, but a mess nonetheless. And so the only way Puerto Rico would consider instituting a mandate is if we got some federal assistance so folks in the territory who are earning between 100 and 400% of the federal poverty line got premium assistance from the federal government. Absent that, it's truly unfair to impose a mandate.
Well, I just have perhaps one question before I turn it over to the audience. And at the Democratic caucus meeting that we had at the White House recently, I had a chance to ask the president, to explain to him some of the issues that we were going through, and he did say that at a point, there would come a point in time when they would be willing to revisit some of the provisions that were creating problems or that needed to have some revisions made to them. So what do you think would need to be done to fix the territories?
I'll take a crack at that. This is something, because the insurers have been very engaged post the bill's passage, we've made this clear to them time and time again. Come up with a list of things that you are challenged with implementing this legislation. What is it that you need us to fix? Again, realistically, we've told them we'll try to address this as much as we can through a regulatory process, through HHS and CMS, but with the background knowledge of when we get in, and I do believe, if it's not this Congress, I think next Congress, or certainly the Congress thereafter, there's going to have to be a technical corrections bill to deal with the Affordable Care Act. Now that it's finally implemented, there seems to be, we're in DC, so everything happens on a slow pace. People are slowly coming to realize that, okay, this thing is for real and we need to make this right. We want to be ready to address things. I think the sort of the initial take would be finding a way, and this is going to be difficult, I think, but for Guam and CNMI would be making sure that the compact migrants are eligible for Medicaid, so we could use Medicaid straight up for their coverage. I think that the individual mandate will have to be addressed in some form or fashion. I think the challenge with that is it comes with, as John mentioned, it comes with a cost. And so I don't know what sort of budget environment we find ourselves next Congress or the Congress thereafter. And then I think hopefully over the next couple of months we'll have a better understanding of maybe more specific challenges that our insurers are facing. But we are trying to get people ready for that because we don't want to be caught flat-footed because if this legislation occurs, like all good legislation, we're not going to have a lot of warning and notice about it, and we're going to have to act. And so we really did want our community to start thinking about, okay, if we could fix this in a perfect world, what would this look like? And then we'll deal with the political and budget realities that exist at that time.
I think the short answer is if the bill is going to be fixed, Congress should do what Congress should have done originally, which is to give the territories state-like treatment. It's ironic because there's 5 territories, and at this point, they're all Democrats. When the ACA was enacted, the House was controlled by Democrats, the White House was controlled by a Democrat, and the Senate was controlled by Democrats. Of course, there came a point where the Democrats lost their filibuster-proof majority when Scott Brown won in Massachusetts. But for most of the debate over the Affordable Care Act, the Democrats could have enacted whatever they wanted. And you have 5 Democrats in the House who are urging equal treatment, and if not equal treatment, as close to equal treatment as possible. And as the Congresswoman laid out, if you look at what came out of the Senate, it was a monstrosity. I mean, we were revolutionizing how healthcare was delivered in this country, and we were just sort of making a couple of small fixes when it came to the territories. So it's hard to not have very mixed views about the ACA when you represent a territory. On the one hand, it was the most important health care bill that's ever been enacted for the territories. The infusion of federal funding was unprecedented. At the same time, a golden opportunity to fix this problem once and for all was missed, and I think it's fair to say that it's probably that ship has sailed. Getting the territories to have state-like treatment at this point is probably a bridge too far, to use another metaphor. I'm mixing all my metaphors, but you get the point. And so when it comes to making individual fixes, I think the main fix is that this Medicaid funding runs out in 2019. So at some point before 2019, Congress is going to have to decide, are we going to renew this funding, an additional $6.3 billion for another 9 years, or are we going to let the territories go all the way back to where they were before the ACA? That, of course, would be a disaster, and you'd see massive migration to the states. So the main thing is making sure that this, at least what we have now, is continued. That would be my main point.
I think what we have now, and the uniqueness of each territory makes it difficult. Guam, I think, with their migrant population, I wish the Virgin Islands had that problem. Our problem is that we don't have insurance providers. They have left because of what the gentleman from Puerto Rico said. Office said the mandates were not fully subsidized as implemented. And personalizing it to the Virgin Islands, every 5 or 6 years, we do an RFP for insurance companies. And then there's a winner, and somebody wins. And then the winner carves out 28 to 33% administrative costs and pass that on to us in the Virgin Islands. In 2006, 2007, our government insurance was 88 million. Now it's 168 million. And we had 10,000 employees, government at that time. Now we're down to about 6,200. This astronomical cost continue to be an albatross to us. So some of us in the Virgin Islands are beginning to have a discussion about a single-payer system, which was the original intent of the Obamacare plan. Is it time for us in the territories to say, affordable health care, you mean well, but let us see what we can do for ourselves in the territories? Is it time for us to have that discussion? And having that discussion is not going to be easy, because there are a lot of people in the pie right now that like it the way it is. And shockingly, there are a lot of Democrats like it the way it is. However, if you are asking for more sovereignty and more independence and more exclusivity, it is time for us as a territory, or even some of the states, to say, let's look in-house, see what we can do to create a vibrant economy, a meaningful economy, wellness as the primary crux of your healthcare industry. And then I believe that if that discussion was to be formulated, we wouldn't even have to depend totally like we do right now on a healthcare system in America.
Okay. And interestingly enough, although they're a lot smaller than we are, the British Virgin Islands, right next door, is preparing to go to single-payer universal coverage with an individual mandate. So, any questions from the audience? We have time for a few questions, comments, suggestions.
Hi, my name is Carol Berkowitz. I'm a pediatrician from Los Angeles, and this has been very informative for me. I really just wasn't aware of these disparities. And so, in building my knowledge, I wonder, are the territories eligible for CHIP, for the Children's Health Insurance Program?
Yes.
Yes.
They do. So, I think most people know the Affordable Care Act continued that program to 2019, but the funding stops September 30th, 2015. And maybe it's informational for folks around here. Senator Rockefeller has a bill to extend it to at least 2019. And in his bill, he also extends CHIP eligibility for individuals who have aged out of the foster care system so that they would be covered under CHIP from 18 to 26. So I might like to encourage folks here to get in touch with their congresspeople to help ensure that CHIP continues. It would again provide
Absolutely.
additional coverage. There are 8.1 million children now covered. If the funding runs out, 2 million children will lose their health insurance.
Well, thank you for that information.
If I could, just one quick
Sure.
vignette on that. Actually, when we had discussions with CMS, Guam was underutilizing the CHIP program. And what the CMS told us was, hey, you have, and again gets back to our compact migrant issue, you have pregnant women from the freely associated states coming, having children on Guam, and we were using local funds. And CMS said, no, you can use your CHIP program to pay for this. So again, that was one where we worked with the local government and said, hey, you're underutilizing a program, an asset and a resource that you have.
Right, so the CHIP program does ensure the unborn child, so undocumented immigrants are covered for their pregnancy.
Well, thank you. If we don't have any other questions, you're going to have a little bit of a break before lunch. Somehow we're on schedule. Any last comments that we haven't touched on?
I would just urge people, when they see statements coming out of the administration about how the goal of the Affordable Care Act is to cover all Americans, all American citizens, to put a little asterisk next to it. I mean, it's not true. There are about 5 million or so American citizens in the territories. In American Samoa, they're not American citizens, they're American nationals, which is a legal distinction without much of a difference. But what's interesting is that the ACA, which all of our bosses strongly supported, does not attempt to provide health insurance to all Americans. It leaves out folks in the territories by basically exempting them, making them ineligible for the exchange, and not providing them with the same level of Medicaid funding that their fellow citizens in the states get. And this is, from our boss's perspective, a civil rights issue, a human rights issue, and it's something that folks in the territories just tend to get less attention. But they're Americans just like everyone else. They serve in huge numbers in the U.S. military. Again, they can get on a plane and move to the States tomorrow if they want, and they're doing that in large numbers. And so having a system set up where you're not providing them the same level of care and then expecting them just to deal with it rather than to move where they can get equal treatment, it's not really a sustainable position. And so the more attention that's, the more light that's shown on this issue, I think the better.
From where I sit, healthcare is not a privilege, it's a human right.
Absolutely.
And asking and pleading for rights have to continue to be a fight. And like the Human Services Director told me a couple weeks ago, that health care is the new civil rights struggle of this day. And all of us need to leave here reinvigorated and committed to ensuring that we get parity for health care for all Americans. You'll be surprised, an email or phone call or text from you to your congressperson or to your state representative, you'll be surprised how much energy that can generate, because we need it. We only have 5 million. You guys have 300 million. And Washington is about numbers. But Washington should be about justice.
Amen.
Then numbers. Thank you.
Well, let's give the panelists a round of applause. Thank you for helping to shed light on this issue, which really many people would not have known,
I think
except
she had
for
a
this
question.
panel. Oh, there's a question?
A comment. She was trying to say
I'm
something.
sorry.
Yeah.
Did the lights?
I don't understand how this is justified legally and ethically. So if someone can just kind of quickly tell me.
It's very simple. The Supreme Court has held that Congress and the President, when enacting federal laws, can treat the territories differently as long as there's a rational basis for the disparity. That's the lowest level of constitutional scrutiny, and so under numerous federal programs, including all the key social safety net programs, the territories are treated differently. The federal courts will never strike it down. The government will come forward with one of two rationales. One, it would be expensive to give them equal treatment, and as the Congresswoman knows, that's really talking about Puerto Rico. To give equal treatment to the smaller territories would be a rounding error when it comes to the federal budget. Puerto Rico obviously starts to cost more money with 3.6 million people and very high poverty rates, which is one of the reasons my boss supports statehood for the island. It will not only help Puerto Rico, it'll help the 4 other territories because they will be able to get things that they couldn't get before because federal government said, no, it'll cost too much to give it to Puerto Rico. There's no ethical justification for it unless you make the argument, as some do, that residents of the territories don't pay federal income taxes on income that they earn in the territory. So a Puerto Rican who lives and works in Puerto Rico doesn't pay federal income taxes on that income. That's often used as the justification for disparate treatment, though as you know, most people who get these social safety net programs don't earn enough to pay federal taxes and indeed get money back from the federal government in the form of a refundable tax credit. So that justification doesn't really hold water.
Okay. Thank you again. Lunch should be served, and we'll come back with some special presentation.